you so much for joining us. And it's a real pleasure for me to be here to introduce Professor Natasha Phillips to share this next hour and 15 minutes with us, the Nursing Now Challenge community. So for those of you that don't know me, I'm Professor Gemma Stacey. I'm the Programme Director of Nursing Now Challenge. And today's session is part of what we've called our Leadership Insights programme. So this is a programme that we've designed specifically for students and early career nurses to give you insights from some key thought leaders from across the world on leadership opportunities and approaches that are very much applicable to you where you are in your current stage in your leadership and career journey. So how do you influence, how do you make change happen when you are entering into a profession that, no matter where we are in the world, is often defined by strict hierarchies? And the principles that we have at Nursing Now Challenge is that we want to try to start to question those hierarchies and challenge and break down some of the barriers that would enable you as students and early career nurses to actually influence, to bring your fresh perspectives into the world of work and the world of practice that you are inhabiting and really make change. So Natasha joins us today to focus on this topic of change, and she is previously the Chief Nursing Information Officer for NHS England. That's where we very first met. And the reason why I say that as part of that introduction is because that was the first one ever, the first ever Chief Nursing Information Officer. And actually that role was pretty immature. There weren't many of them in the country. And Natasha was a real pioneer in enabling the world of NHS practice to understand the need and the importance for nursing leadership at the most senior level when organisations were embarking upon their digital transformation. And has since then moved on from NHS England and now works consulting into tech in organisations, working with healthcare organisations to prepare and manage their organisational change around digital innovation and data, and also leads a phenomenal organisation called Future Nurse. And Future Nurse is a community interest company, all based around building community and influence through nursing and midwifery into the technology and digital transformation space. And Natasha will be able to tell you loads more about that organisation and how you might be able to get involved going forward. So I'm going to hand you over to Natasha now. If you've got any questions, thoughts, reflections as Natasha's speaking, pop them into the chat. And at the end of the session, I will have opportunity to put those either to Natasha live today if we've got time, but if not, following the session, and we'll post them out on our social media. Over to you, Natasha.
Oh, Gemma, thank you ever so much. And I'm just going to do the tech bit first, which is always the most nerve-wracking bit, isn't it? Getting the tech to work. So let me make sure the slides are working before I get speaking. So let's pick that deck and then just go here and tell me, can you see my slides?
We can see them, yeah.
That is wonderful. I'm so grateful to Gemma and Nursing Now for inviting me to speak. Like Gemma, I have a really strong passion for supporting early career nurses, student nurses, and nurturing the future of our profession, which the future of our profession are the people. So we really have to take care of each other and nurture and create opportunity. And I think both our organisations have synergies there in having a shared sense of purpose. So I'm really thrilled to be with you all, and it was amazing seeing the variety of people in the chat from all places and at different stages in their career from what I was seeing there. As Gemma said, please put lots of questions, thoughts as they occur to you in that chat, capture it, have a side discussion with yourselves as well as I'm speaking. If something triggers a thought and it resonates with you, use that chat function as much as you like, and if there are questions and that there isn't time to pick them up, I will of course chat to Gemma after, and we'll make sure that that those come back out to you. But really, there should be a space for discussion as much as we can make it so, given the constraints of technology, and even just the different time zones that we're all on. I'm sure our heads are in different spaces. Some of us are ready for bed. Some of us just want to get to our dinner. Some of us have just got up this morning. So a tricky space to work with for what I would normally do, but I'm going to try and do my best for you. You'll notice in the left-hand corner, there's a QR code which you can scan, which will take you to the Future Nurse website, which you might want to bookmark for the future. So I'm going to craft this session taking you very much through my journey leading change from where I am, and I'll take you through all the different points where I've been leading change, and I'm going to ground this in some research that I did as part of my journey. But that's the trailer. I'm not going to do any more spoilers. Let's just see how we go. So let me tell you a bit about my story and my early career. You'll see a picture there of a hospice. That is the place where I started nursing back in 1993. So many moons ago. I was a healthcare support worker in a hospice, and the reason I always start my journey here is this is where I learned about the fundamentals of nursing, person-centered care, and what that truly meant, which was I could give great care to my patients because I was situated in an organization where I was really well cared for. And that's important as I go through this story because I know it's not always so. So if we think about what happened after, I went to be a student nurse where you bounce about from placement to placement, and we've all experienced the variety that happens there. Sometimes we're really well supported, other times less so. It's a tough program that we put people through, and they need quite a lot of resilience. And Gemma and I frequently question, is it right to expect people to rely on resilience, and how do we support them with that resilience? And importantly, how do we create resilient organizations? So that will be some of the themes coming through as I go through this long journey of what is quite a long career now, over 30 years. I can't quite believe it, and it makes me feel old. I don't feel that old. I still feel like Natasha, that student nurse who arrived after this wonderful experience, walked into hospital and went, why have they made it so difficult for me to do my job? And got very frustrated and was constantly looking at ways to change things. And that's probably a core part of who I am as a person, a core part of what the situation I found myself in, but it's certainly a red thread of narrative that goes through my career. And when I speak to other nurses who lead change in practice, they often have quite a similar story. So I'm going to skip on to this slide here. So I've got through my nurse training. I've had jobs. I've had successes and failures in leading change all along the way, and find myself as deputy chief nurse in an NHS, a National Health Service hospital here in England. And I am tasked with leading a huge program of change called the Productive Ward Series, which was really about supporting us using data to know how we were doing, to drive large-scale improvements across our clinical areas. And I was responsible for leading that across the whole organisation. And what I found was it's quite difficult. And many of the people who I was leading, who then went on to lead others, also found it difficult. And what I noticed was the actual nuts and bolts of what we were asked to do, using, for those that might be familiar with it, lean methodology. So, using improvement science to do those changes. Well, hey, that's not so hard. It's very much like the nursing process. Just as we have a process of assess, plan, implement, evaluate, PDSA is the QI version, which is plan, do, see, act. So there is a constant cycle. Really easy for us nurses. We're doers, we're practical people, not a problem. So why was it difficult? Because it's difficult convincing other people to change, perhaps, and leading that change. Why is that so difficult? And I found people that were saying, I'm finding this really hard. And what I thought I would do was do something called action learning training, which I did, which was helping people to create something that I'm going to come on to in a bit more detail, reflexive spaces where people can think about the work they're doing and how they might adapt and change in order to be successful. That was really interesting. It led me on to do some further studies. And eventually I find myself at this point going, I've tried everything. I've put on a leadership program in-house for these people. They've had some huge successes. It was project-based. They got to do projects that improved things. There were some successes, but is everything fixed? No. So still in search of the answer, still a little bit frustrated as someone who was leading change from the position of being a deputy chief nurse in a reasonably sized hospital. I decided to embark on some doctoral studies, which is probably quite mad, given that I had 2 young children, a full-time job, and was now adding to my commitments by doing this study. But I really wanted to understand what was getting in the way. How might we get to that point where everyone could just fix everything that was broken? And in my mind, I thought with my research, I would find a typology of the ideal clinical leader. And of course, unsurprisingly, that's not how it panned out. What I found was that we needed to equip people to lead in this complex system that we work within. So rather than suggesting that there is an ideal, and these are very British pictures of our ideals of what clinical leaders are. So a title called Ward Sister in the blue, and matron there in the middle at the end of the bed, who everyone would have been very scared of back in the day, and was, so we had a very hierarchical structure. And what we would see repeatedly were calls to bring back this structure, and this was magically going to fix it. Well, I found ward sisters doing all sorts of things, but mostly what they were trying to do was make practical judgments in everyday practice, and that sometimes caused them moral distress. So my findings pointed to the fact that really what we need to do is equip people with the courage to stay in that situation and the wisdom to make practical judgments through reflective practice, so that they could execute their roles in a way that sat with their values, so with a moral justice that served the frequently competing expectations of their patients, their staff, and the wider NHS. So let's go on and unpack that a little bit more. So I guess the paradox, the challenge here is that nurses see exactly what needs to change in patient care, but what we've heard is people lack the power, the title, or the authority to change it. That was the prevailing narrative as to why our health system in the UK wasn't where it needed to be. And that's what was frequently called for. So we would have programs whereby a national matron program was implemented, where matrons were all created overnight. Lots of restructuring in order to fix things and make them better. And through the research, what I found, so what were people actually doing in their everyday work? And this probably sounds very familiar to leaders amongst you. I don't think this is UK centric at all. This is global. The work that we do is global. So managing that flow of patients, or language that I would prefer to use, coordinating patient care, which is much more human and person-centric language, but the language that's evolved in our system here has become managing patient flow. Managing resources, staffing, equipment, and so forth. And an important element of work that has grown up in recent years is this concept of providing assurance. So that exhausting demand to consistently prove, measure, and audit that care is safe and efficient. So you can see you're working in systems that are not just complex, but are complicated. There's no single right answer, only this constant balancing of tension as you try to do the work and make judgments about what to do next. Bear with me, I'm just trying to get the slide to move on. So what I learned was that there's this illusion of control. When we talk about leadership in healthcare, we usually mean position, authority, and hierarchy. And if we get that right, everything's going to work beautifully. And as a frustrated early career nurse at the beginning, if I just get to the next step on the ladder, I'm going to be able to have control, have power, and do what I think needs to be done. As someone who's climbed that ladder all the way to the very top of the tree in NHS England here in the UK, I can say that really is an illusion. So wherever you sit in the system as a leader trying to achieve change, the hierarchical structures and process are only part of the story in how you do that. If you rely on that entirely, you are unlikely to achieve your goals. So what happens when we focus on that is what we're trying to do is fix complex human problems with rigid management policies, and we're assuming that the power is this thing that is handed down from the top to another person, and sometimes we wait to be given the authority to lead, and the thing that we need to do most is not wait for that authority. So my lesson through this research was leadership does not sit in a job title, and there are no ideal people who fulfill those job roles. It lives in the ongoing interactions. So power to make change isn't a static object that you hold. It's a dynamic process negotiated in real time in every interaction that you have. So let me illustrate that with an example. So here I've got an image that shows you the ebb and flow of power. Okay. And what you can see here is all the things that come together as conflict and competing demands when we are trying to lead change. So you will invariably be holding in the same moment the needs of your patients, the executive targets, the needs of your organization, perhaps the needs of your colleagues or staff, and trying to work out what's the right thing to do. So a really good example from the research, a really simple one that will probably resonate with everyone, or at least those working in hospitals. There probably are some community parallels, is this example of bed management. So I'm going to take you to a cancer ward where the ward sister who I was observing was standing at a board with all the lists of patients making plans and the phone's ringing. She's being asked by the clinical site manager for a bed for a patient that's waiting in the emergency department. But she knows that one of her cancer patients is due in and had been allocated that bed. And that cancer patient's needs are they need to get in and have their chemo, and they'll be quite anxious if they don't make it into the hospital. She really identifies with her cancer patients. So her value set is very much grounded in my specialty and my people. She's also got staff who are feeling quite overwhelmed from the constant demand for expediting patient flow, pushing more patients through having to care for patients who they don't feel as skilled to care for because they may not be their speciality that's come from the emergency department. What does she do? She brings it all into view, and in that very moment, she uses her power to make a change. So she makes a practical judgment that says, I'm going to say this patient's already in the bed, even though they're not, because then that bed is protected for my patient, and I will deal with the consequences thereafter. You can see the sort of tension that creates for the individual, and the potential repercussions for that person. So in that moment, their commitment to their cancer patients overrode their fears and needs to stick with organizational policy and those executive targets. And that's the sort of work that people do every day. And in those moments, a change happens. Power ebbs and flows. So it's not that the executives held all the power because they set the policies. The ward sister was in a position where she could make a judgment, but in that moment, she's powerful and powerless. She doesn't entirely hold all the power. Her staff hold some power. They jump in and say, actually, we're not ready to take another patient from ED, and we'd much prefer to do this. So everybody has got power if they engage in the interaction. So we're all in a constant state of interdependence upon each other. And so the uncomfortable truth that I learned about systems, and systems thinking is very prevalent in the UK, and in some other parts of the world, like the US. I'm not sure, in some cultures it might not be so prevalent, but we're very focused on systems thinking. So in that thinking, the system is something out there, okay, that you do too. Where in this way of thinking about how we lead change, we are in it. We are part of the system. And so the hardest part of leadership is not changing others, it's understanding how you are part of what you're trying to change. So every time that you speak or respond or question or stay silent, you too are shaping the system. So you, in fact, have some power to influence within that system that you are part of. So let's just unpack that a little bit further and think about, so let's think about the two different perspectives on clinical leadership and leading change. So in the systemic way, in the orthodox view of this system with structure and hierarchy, the view of power is that it's static. It's a static authority that's given to someone by their title, be they the nursing director, the ward sister. The title is therefore the power. But in fact, we knew that in our study, those very people felt powerful and powerless, often in the same interaction and multiple times in different ways within the day. So in the reflexive view, power is negotiated all the time in every interaction. It ebbs and flows. So as a leader, if you think about that, that helps you to think about how you might lead differently. In the orthodox, the systemic view, it's about following the policy and systemic compliance. And so policymakers will say, we're going to do this policy and then everything will be right if everyone follows the policy in that way. I have never in my whole career seen a policy translated in a linear fashion in that way. And certainly doing this study where we looked at how people take up policies like the bed management policy and operationalize them isn't in that way. We just saw that ward leader just decided, today I'm not going to follow that policy. I'm going to make a different judgment. So actually, in the reflexive view, it's about practical judgment and navigating the context, which includes those policies. The nature of the role is different from each perspective as well. So in the orthodox view, it's about position and control, managing the unit. In a reflexive view, it's about being relational and responsive and connecting the people that you're working with and connecting with those people as a leader, recognizing that we're all part of the problem, part of the solution. So the mechanisms of change are quite different, and we've seen a lot of this here in the UK in lots of ways over the years. And my whole thesis did a whole analysis of some of these restructures of leadership in our profession here in the UK. But the traditional way to approach this is to go, oh dear, no one's following the policies, the structures aren't working. What we will do is we will restructure, and if we restructure things, we will get the outcome that we want. We will see the change we want. The policy that's been created will be implemented in just the way the policy creator envisaged it. In the reflexive view, a more pragmatic view, arguably, the mechanism of change is interaction. So by changing the conversation, we achieve change. So let's just pause and think about that and think of a tool that you could use in order to grow your own skills of reflexivity, in order to become better change leaders, better nurses. And we're all schooled in being reflexive, but reflexive being slightly different to reflection. So reflexive in action, in the moment. And it takes quite a lot of practice. So paying attention to what's happening between you and the other person you're interacting with, or the numerous people you're interacting with in the moment, in the thing that you are doing. Noticing what's going on, what feels off, what's important, what's unsaid. Responding in return to what you notice through what you hear and what you see. in terms of an action. So taking a small intentional shift to step to shift that interaction with another person. So I am not getting where I need to in terms of influencing them for change. What am I noticing about where they're at with that change, with that ask for change? What are the unsaid things that might be influencing why I'm not having the impact I want? And then maybe making a shift in order to respond to what that person has given you in what they've said and in their physical body language. Then keep reflecting. What is my role in this pattern? What have I learned from this? When I go into the next cycle of interaction with someone else, what might I do differently? And this is continuous, never-ending ebb and flow. But keeping a journal, if you're really focused on trying to sort of develop your change skills, if you're leading a change project, not just having the project plan, but also making some notes about some of this stuff over the journey of it, are likely to yield you some new insights that would help to lead that change from where you are. So this isn't a management tool. This is daily clinical practice. So I'm going to pause and just give you a couple of minutes just to take some time to think about a frustration in your practice or something you're trying to change. And just based on what you've heard about a different paradigm for leadership and for organizations, not as systems, but as processes of relating between human beings. Think about that situation and just jot down in a notebook or something or on your phone, what was actually happening in the interaction I've had around this? Why am I not getting where I need to? Why is the pattern persisting? What am I doing and what might I do differently that would enable me to unlock, through working with other people, the change that I want to achieve or make something different happen? And unlocking may mean that you change your mind and go, this isn't the right thing that we need to be changing, or this isn't the right process we need to follow to get to that change. So just take a few moments and I'm just going to sit here quietly. You're welcome to put things in the chat, your thoughts on this, or this is just a personal exercise for you to do. I'm not going to put anyone on the spot and ask them to tell us about the work that they've done in these few minutes, but I'm going to give you till 3:30. We're on 3:33, so in about 5 minutes at 3:37 I'll come back and we'll continue with how I've moved from this research into some of the change leadership roles that I've had in my career and the difference between those roles, but how this has been a core part of the way I've enacted those roles. Right. In the interest of time, I'm going to move us on. And I believe the slides are available to you after, so you could always go back to this tool. So I'm just going to sum up before we move on that 7 years of learning, actually. Most of the PhD written outside dance lessons from my daughter. So a long period of time, 7 years of painful leading. And I guess what I learned through that research was I'd set out to fix other people and find a typology of ideal nurse leaders that could just be cultivated and fixed. And what I actually realized was the most helpful thing about those studies was I was making sense of my own leadership and how I might practice leadership in a way that had less emotional labor for me and enabled me to have more impact, and in turn then enable me to help other people. So it was a really useful, if somewhat long and often painful exercise. But let's come back to what the whole concept pulled together of what is leading through complex responsive processes of relating, which is the academic term for this, which is a bit of a mouthful. So I've tried to stay away from it. So we can see in the reflexive nurse leader model, we move from hierarchy, focus on hierarchy, to a focus on interaction. Okay, so the traditional view being all about position authority, top-down instruction. We move into a space where we focus on interaction and learning from our interactions. So in this view, the system is viewed as evolving patterns of people focused on self-reflection and reflecting together and interaction. So very much focused on the group and how we interact with others, not just self, but the impact of self as instrument on others. We can see that leadership lives in everyday interactions. It's not just a title, it's what happens when people speak, respond, or question. So actually, that has the potential to be very empowering, because what that means is we are all leaders. We are all leaders, and sometimes we are followers. Small shifts can happen in those daily conversations. The hard challenge is knowing which one's going to make the difference. And that's why every conversation matters. And you have to work on this through everything that you do. Systems are patterns of people. They're not these very rigid structures. And the hardest part of leadership is understanding how you are part of that system that you want to change, that you are not, as I thought originally, operating outside it as the leader with the positional authority to make change, but you're in it with everyone every day. You can influence without permission. You are already shaping the system, you're already leading. Start where you are with the relationships that you have to achieve the change you want, be it big or small. So now let's move on to application in practice. And I'm going to go back in my career now. I'm going to start shifting back into my story. We've got to the point where I've done some research, I've led some change programs, I've got the scars to bear it, and I'm now stepping into other roles, leadership roles within the NHS. And I'm going to fast forward in some time to a time when I was leading digital transformation. So over the years, I've become more of a digital leader, arguably because digital healthcare is one of the key levers for solving some of the challenges that we face globally for health. However, done poorly, it is unlikely to have the impact that we want. And we know from the research that we're already feeling the effects of that as nurses. So really, this is as the technology is only part of the story. And this is where I step in as Chief Nursing Information Officer in a very large acute trust in London. We have 9 hospitals, 10,000 staff, and we are going to deploy an electronic patient record across all of those people. And on a given day, we will switch people from a multiplicity of systems and a large proportion of paper for managing everything to do with patient care, to a new system, the electronic patient record, where we have one patient, one record, everything happening in one space, everyone being able to interact with that remotely. That requires a lot of change management and a lot of support for people. And interestingly, I've just put a graph from some research that I find really interesting in this space. So what you're seeing on that graph is the big blue blurb is lots of bars of hospitals, and this is global data, who have implemented electronic patient records and done a usability survey. How useful do staff find this system? How helpful is it in terms of things like patient safety? How much of their time is it taking away from patient care? All of those sorts of questions are caught within a survey, and these are the publication of those survey results for all of these hospitals. And the arrows that you can see, the different coloured bars with arrows, are different EPRs. And what's really interesting about this is you will see from those arrows that the same EPR can be at the top of the chart for performance and at the bottom of the chart. And I think what that really points to is that the technology on its own, just like hierarchy, system, process on its own, don't make the change. We make good change, and people have a good experience of that change when we focus on people and process and focus on what the people need. So the way that this was approached was to bring all of that learning from research into the way that we engaged frontline nurses to be part of the change, all frontline clinicians, all frontline staff. So we had a big clinical leadership team doing a lot of work, making sure that they were listening very actively and designing based around what they were hearing, and through their work building community where people were working with each other. And despite the obvious reservations that will exist, some people excited, some people nervous, through creating the space, people were able to explore that. And at the point of go live, we had the first successful enterprise-wide EPR go live in the UK. It was a huge success, and in large part that was down to the approach that we took and the focus we took on people. We had a really basic minimum level of expectation for this go live. We didn't want to find anyone crying because they were really struggling with doing their work on the day. And fortunately, we didn't. And more importantly, we didn't have any patient safety incidents. And more importantly, within a week, people were saying, please don't take this away. This is really good, but here's some changes I want. And we continue to work on that change cycle together to update, upgrade the system. And that continues in that organization today. But a real example of how focusing on people, focusing on creating the opportunity for them to communicate in reflexive spaces together could deliver real change across a system. I'm now going to talk about leading from the policy space. So when I was doing that role, much like when I was a junior staff nurse and had ideas for change and sometimes felt a bit lonely and would find allies to take that forward, or the other leader that would support me. When I was leading this change in as a very senior nurse, a chief nursing information officer in a huge trust, I was one of very few of those sorts of people. Gemma mentioned it earlier, here in the UK. And I recognised how hard it was, and that I had to reach out to the global community who had experience of this change for advice sometimes, to make sure I was doing the right thing for and with my colleagues. And I thought that was really unfair, and that every trust should have a senior leadership role and invest in supporting the professions to be able to make these changes. So I stepped into the policy arena at this point. So I stepped into an arena which was complex, high complexity. So NHS England runs the whole of the NHS system in the UK. So all of our health, from hospitals to community care through to general practice, primary care, everything. Massive organisation, really complex. And with all big organisations, lots of siloed working across different parts of it. And into a really conflictual space as well. So at this point in time, many senior nurses are very nervous about digital and that it might somehow undermine what we want to do as nurses, not really confident in where technologies could help and where they might be a hindrance, and therefore not able to advocate for others in what would happen. So a really conflictual space, working across a nursing directorate which held a view, some like that, some going, yes, help us, Natasha, we want to do this, some really reticent, and then into other parts of the organisation that didn't really think nursing had a place in this space anyway. So, could you just go away and not get involved and leave the technology to us? So really challenged time to step into as a change leader. So what do you do? So I come back to one person, one leader does not fix everything in an organization. One leader can't make all of the change that's required to achieve the outcome we wanted, which was for every nurse in England to have access to technology that supports them to do their job. And my personal ambition for every nurse in England to have the knowledge and skills and be sufficiently empowered to not only practice in, but to lead digital transformation, to take on all the sorts of roles that we need to start to keep crafting this and reimagining how we might practice our care. And this image is from a listening exercise where we've brought lots of those people together to start to understand what do we need. So before I start to act as a policymaker, I need to really listen and I need to really reflect on what I'm hearing, who I'm hearing it from, what policy says, what policymakers say, what they don't say. Take all of that complex data into vision and think about how are we going to craft a plan and who do we need to be involved in taking that plan forward, and building team as a change leader that's going to be able to do this. So what was the impact? We had a shift from 20% to 80% of NHS provider trusts have a chief nursing information officer, and that was as of 2023 when I left NHS England. That we started to achieve stronger nursing involvement in the procurement and deployment of technologies in healthcare provider organisations by creating community. What we focused on was creating network community where people could support each other, reflect with each other, work out what learn from each other in terms of what they would do. So a sort of drawing on theories of social movement to empower lots of people to make change, and that the sum total of that change would be greater than all the individual parts. So, and in so doing, we saw that play out. We started to see more nursing involvement in the procurement and deployment of tech. We saw more investment in research around digital healthcare here in the UK, and we started to produce some of those policy documents, national guidance that provide the blueprint for organisations where digitally enabled care can thrive. Interestingly, I guess with this is I knew that that's really helpful, but it only takes you so far. And we can't imagine that the guidance will just be picked up and implemented in the same way in every single place, where I think that's generally an assumption that's going to happen. By not having that assumption, we could be more helpful with people in terms of saying, so what do you need to implement this? And trusting them to do it differently, not trying to control everything. Leading change doesn't always mean having an idea that you take from A to B in a linear way. Leading change sometimes means that you change your very own idea of what that change might look like over time. You cede control, you allow for that ebb and flow of power with others as you're working with them. So arguably, one would think I've got to the top of the tree. I am a national leader. I lead policy. I'm going to have fixed everything and that'll be it. And I'll bow out and go somewhere sunny on my holidays. But of course, that's not really how it works, is it? So much was achieved. There's much to do. And I think what I learned is the ways that you could use policy levers, so conversations that lead to artifacts like policy documents as levers for change, really helpful stuff. But what do you do when you're not doing that anymore? So I wanted to step away and get right back into delivery. And so I now run an organisation called Future Nurse Consulting. And again, you're now leading without formal authority. So you might assume that you're not going to be able to make a lot of change compared to having such a position in that traditional hierarchical view. But of course, that's not the case. And I knew that would not be the case because of the leadership journey that I'd been on over all of those years and the learning that I had gathered. So I'm going to give you an example of one of the consulting projects that I do, because I think it illustrates again about how you lead change, with how you create the conditions for individual nurses, particularly early career and frontline nurses, to be able to use their voice. So it's all very well for me to sit here and say, so be really reflexive and then just get stuck back in there and see how it works. But that takes a lot of resilience. How do organizations create the conditions? And organizations have a responsibility to do that as well. So as we grow as leaders and we're supporting others, we all have a responsibility to create the conditions for others to lead. And that was part of what I was asked to do here in this hospital. So they wanted to have a ward accreditation model, a model of assessing how wards are performing, that they can assure themselves that things are going well. And what we encouraged them to do was say, well, let's think beyond assurance to what if we use this as a culture program to create a place where people feel that they are part of continuously improving the environments where they deliver care. And so we co-created this model of what that ideal clinical practice environment looks like with clinicians and staff. And we came up with this weighted model of the things that you would need to have in place in order for that to happen. And being a digital and data nurse specialist, we came up with a data model that supports this. So instead of subjective just checking and saying you're a good area today and you're less good, and I've done a walkabout with a clipboard and you're good, and tomorrow you're not so good because a pressure ulcer happened in your clinical area or something, we came up with this weighted data model that replicates professional judgment, and everybody was involved in building it. So from the get-go, people are involved in deciding what they think their clinical environment should look like. And we started with one question: when a clinical area is flourishing, what does that look like? And unsurprisingly, people talked about their own experience as a staff member and what that would be like, as well as some of the more, the things about what our patients might expect and about having evidence-based and harm-free care. But really recognizing that the staff experience, your experience in that area, is a fundamental part of whether that's a good area to work and patients get good care or not. Beyond having a data model, and most people that I interact with as a consultant say, lovely, we'll just go and put the data model in. And I work very hard to say, if you do that, you will not see the change you want to see. You are just creating a measuring stick. What we did with this organization is create an education program, and we took people through some knowledge and skills study days around leading change, leading people. Some of the stuff that I'm talking about today is on that course. We also gave them the skills of continuous quality improvement, so some practical tools and techniques for doing changes that will impact the metrics about their clinical area, and empowered them to make their own journey choice in terms of the things that they focused on to improve. So not set by someone else in a position of hierarchical authority, but that ward team deciding together the things that they wanted to work on. And we saw huge success with that. And that organisation has gone on to win awards. As a key part of it, the programme also focused on constructive, reflexive conversations for continuous improvement. And so it doesn't stop in the classroom. It's about change coaches going out into the clinical area to support people and sometimes challenge each other around what's going on in a really positive way. And that organisation has gone on to go we commissioned that, but we realised now it's part of this bigger things. They've bought a whole smorgasbord of things to make things better so that they could be judged as an outstanding hospital. And what we see actually is they fit beautifully together. And what this organisation has done really well is, if we look at the pieces on the jigsaw puzzle, they've created lots of spaces for people to be reflexive individually and with others. So shared decision-making councils, following that pathway to excellence model, having something called professional advocates, so people trained to support people to reflect and trained to support people in practice, using programs, leadership programs like Leading Empowered Organisations, so bringing it all together to create a culture where staff are valued and value themselves and have the support to develop those skills of reflexivity in order to work together to build the sorts of wards, departments, clinical directorates, organisations that they can be proud of working in. So that's an example from consulting. And the interesting thing about leading change from a consulting perspective is, what I notice is, as someone who has been invited into someone else's organisation, often they're much more willing to listen than when you're in it. And that was a real interesting point for me as a reflexive practitioner to think about. So what does that mean? How do I use this well? And how do I pay attention to it doesn't leave me going, let's just do it the Natasha Phillips way? So there was some real learning for me in terms of leading that change as a consultant. And the fact that your values, part of our core values is an identity with our own organisation. I don't identify with that organisation. So what does it mean? What does it mean for me? How do I and how do I step away? How do I step away when the change is done and not continuously try to own it? How do I allow them to evolve that change and take it in the direction they want? And that's all been a real rich area of learning for me over the last year. But it just illustrates that I didn't have a position in the hierarchical authority chain of that organisation, but I could still lead a lot of positive change by sticking with the premises of the things that I'd learned over the years as a change agent. And then I'm just going to come on to my last example of leading from the back benches. So the Future Nurse Community Interest Company that Gemma mentioned. So what are we about? It's about bringing nurses and the health tech industry together. So thinking differently about organisation and who works with who, thinking about the health tech industry having a value to bring to us, having their own body of knowledge, and that they should respect the nursing body of knowledge, and likewise nursing respect theirs, and in coming together, imagine what they might create. So we've seen lots of nurses get involved in the deployment of technology, but not so much in the ideation space. So our premise is we think there's more to do there. Nurses know the problems that need solving in our healthcare systems, and if we create the conditions for it, we may be able to liberate some of that thinking and perhaps come up with new technologies. We know that a lot of our time is wasted as a result of poor tech or poor processes. And so that's what we work with the industry for. And how we support nurses is supporting them into training. So we do very early stages of some programs that we run, but we would like to scale those to support nurses, and we connect nurses all the time. So learning through networking and education, bringing nurses together to support each other, but also bringing nurses and industry together and amplifying and promoting the needs of nurses through our ongoing dialogue with industry. And importantly, the last part, I would describe Future Nurse as a think and do tank. So how do we influence policy? I've said to you that policy can be a really powerful lever for change, and it's something I wish I'd learned to understand much earlier in my career. So how do we influence policy? And by policy, I mean national policy, policymakers, so that nurses are involved in the development and selection of the tech. So everything that we do, we aim to put an output into the world in order to create conversation and inform others about why this issue is important for our profession. We have something called the Digital Nursing First Alliance, which is how we hold industry to account to some degree, or how we work with industry. So there's a bit of assurance, but a bit of working together. And we have said we think that of the 50% of non-value added time that nurses spend with in direct contact with their patient, we can release some of that. And I've probably said that wrong. It's not that it's not value added, it's just that it's not directly with the patient. So there's a lot of time that we could take off documentation, which means you could spend more time in relation with patients. There's a lot of time in terms of transmitting information around the system, meds admin, all of that is ripe for technologies and automation that could give nursing back time. But we have to be really careful about claiming that time back and then how it's repurposed. And a lot of our focus is in getting this happening. So moving nursing from a place of passive acceptance to a more proactive place of influencing policy and saying, this is how we want to practice our nursing, and this is how this is the technology that we need, and this is how we want to be involved in shaping that technology. And so really that's all achieved by just building community and giving people opportunities to get into spaces where they can use their voice. So that's quite different to when I was CNIO for England and I could do lots of telling. But what I've learned through that process is that there is real opportunity for us to use our voice in all sorts of ways, that we are always a nurse and we can use our voice wherever we sit in the system. It's what we're endeavoring to do here is create the space to co-create the future. So I don't know where that will go. All I can do is stay present in the messiness of this thing and see what happens by bringing diverse groups together and not trying to control everything that's happening in that space. But that doesn't mean that I don't have a plan, that there isn't a plan. I wouldn't want you to come away from this session thinking, oh, well, we throw systems thinking out of the way, we throw planning out of the way, and all we do is focus on the conversation. There still needs to be some element of a plan, but that plan has been co-created with others so that the principles of listening and thinking are still in that plan. And I think a really good example of that is how our AVT specialist interest group has emerged. So from the conditions we've created, we notice through our chat forums, lots of nurses talking about AVT and saying, I want to do this. I think it's a great opportunity. I'm nervous. I don't know what the regulation is. I'm a bit worried about patient safety. I really want to connect with other nurses and do something about this. And I really want some guidance to come from a policy perspective around this. So we heard that. We acted and we've built momentum. So we now have an active sub-community within Future Nurse entirely focused on ambient voice technology, who are doing lots of work as Future Nurse activists. And we've partnered with academia and industry to run events whereby we've harnessed all of that voice, which will be put together as a white paper, a paper to influence policymakers. So that will be distributed amongst policymakers, industry people. All the nurse leaders here in the UK would receive such a document. And that's the role of leading change through influence and policy influence. And it's often a really slow game. And that can be very, very frustrating. But that's the nature of leading change at that scale. Often as a frontline nurse, you're not having to deal with it at that scale, but you should still be thinking some of those questions. Who do I need to influence? Is there a policy that we've got in the organisation that I can connect this back to, or an organisational objective that's going to help me achieve that change? So let's go back to the theory. So the scale of your influence. Not all influence, as I just inferred, looks the same. But all of it matters, and it all starts with a single interaction. It all starts with speaking to others and paying attention to what's going on in that interaction with very clear purpose to get to where you need to be. So it might be just simply changing a process in your own clinical environment. It might be a small improvement, like fixing something, creating a new process or in your department, a small quality improvement project that it gives a better outcome for a patient or for staff. might be redefining care, influencing global digital health adoption, like in my case, nationally and globally, using that influence. So the scale can change, and it doesn't always matter where you are in the hierarchy. You might be influencing across all of those at different points in time. Remember this, if you take nothing else, the reflexive influence cycle. So think about that cycle of being reflexive in action, not on action, not afterwards, although that is also valuable, but in action, paying attention to what's going on. So not just solution focused, not just outcome focused, but noticing what's going on in the interaction and what that means for where you want to get to. This is a really useful group tool as well to use. So being reflexive with others who have similar experience to you, so you learn from each other's experience of trying to achieve whatever it is you're trying to achieve in your local area. So why does this matter now? Well, I think as healthcare becomes more digital, more fragmented, the demand for health has risen exponentially. Our capacity to meet that need is is more challenged. So healthcare has by default become more complex. We can't just rely on top-down instructions. We need frontline leaders like yourselves who can navigate that tension, exercise practical judgment in the moment, and shape the system that they work in from within as part of that system. So you are already shaping the system. Don't wait for permission. Don't wait for a title. Don't wait until you feel ready. You'll never be ready. You are ready. Start with where you are, with what you see in front of you, and with the relationships you already have. And that's it from me. I'm going to stop there and hand back to Gemma to facilitate any discussion. I will stop sharing my slides now. And that QR code is the same QR code if you want to sign up to Future Nurse.
Brilliant. Thank you so much, Natasha. That was just really excellent and really honed in for me that point around the continuous learning. There were lots of points where you said, I assumed this, but actually I learned this, and that's been a defining feature throughout that whole journey. So thank you for that. There are a couple of questions that have come through. The first one relating to the implementation of AI and the rhetoric we're hearing around this being a solution to reducing the burden of documentation on nurses, and whether that burden might translate to opportunity to spend more time in contact with patients and people we're supporting. What's your thoughts on that?
It's a really interesting point. So I think, like all of these technologies, there's huge opportunity, but only if we're really clear in our purpose about how, where, why. There's lots of rabbit holes we could fall down as nurses. We have to be really cautious in it, but we don't want our caution to get in the way of progress. I think there's not enough nursing voice in some of the global and national conversations about AI and AVT. Let's not beat about the bush. There is risk in this. I feel we're very much back to when the internet was formed. AI is in that very space. It's a big bubble that could burst. There's a lot going on. But on the positive side, through our AVT SIG, we know nurses who are working in this way and gaining real benefit. But the ones that are doing that well are thinking very specifically about the use cases. In the AVT space, most of the suppliers, the use cases are focused on one-to-one clinic appointments. But we know for nursing that, we practice in all sorts of environments. So how do you use AVT in a 6-bedded bay in a hospital ward if you've got more, if you haven't got single rooms and it's noisy? What does that mean? And what use cases is it good for? Can you use this for assessment? How do you use it out in the community in someone's homes? That's the hard work that we need to get into and start defining. And that's the work that we've been doing through the AVT SIG. So we've pulled together the evidence of over 344 papers. I'm sorry, I'm a data geek. Of 344 papers, only 12 are specifically related to nursing in this field.
Wow.
Yeah. So we need to be part of fixing that, don't we? And you
Yeah.
and I work on that all the time. Let's generate the evidence, but we've looked at the evidence. We're looking in practice as well. We've had roundtables, and a recommendation paper will come out. And later this week, if you follow us on LinkedIn or get to the website, we're putting the visual artist output, which articulates really clearly what the nurses have said to involved in this piece of work have said they need, which is AVT is lovely, but it won't realize those benefits if we just focus on the financial gain and the time saved, which is the rhetoric at the moment, which is scary. So what does it mean for patient safety, experience, and so forth? They've said that AVT on its own, just creating a document, doesn't help me. It doesn't save me time. AVT that triggers actions, so using agentic AI to trigger actions where referrals go to other people, or different things happen upstream for the patient, is where the benefit is. So I need it to be wired into my EPR as well, because then it's drawing from a wealth of data to do that. And where they really want to be is in a place where it's enabling them to do that. That really hard bit about joining up care across the system that basically nurses do because they're like the glue in the system. We'd like it to fix that, please.
Great, thank you, thanks. And just building on that, Natasha, thinking about obviously our demographic from all sorts of different socioeconomic backgrounds, resource environments for where nurses and midwives are working to deliver care. Have you thought about what the implications might be for potentially widening those inequalities of health where there might not be access to this kind of technology?
Absolutely. That is the risk, isn't it? That we just widen health inequalities hugely. I teach in Manchester, where the average reading age is 8. And there's huge areas of sort of deprivation. So we see some of those health inequalities in terms of how people can either access the technology, have devices, or even interact with the information. And when I teach that program, I run a program where nurses who are doing digital transformations in their organizations, or changes, that we had some really good debate on that discussion about how they're doing it. And there are lots of tools that people are using in order to make sure that they are attending to that. But the key one, I guess, is involvement. And just good PPIE, good involvement of people to design, and always having an alternative to the digital solution for those that can't access has to be a core part of the process.
Thank you, thanks so
The
much.
converse side is, if I may elaborate, is I do think it could help to close some health inequalities
Yes,
as
there's
well, by
potential there.
reaching people in place where it's harder to reach people. So there's real opportunity to think about how might a piece of technology or some digital infrastructure actually help us to narrow that gap. But I don't have all the answers on what those are. I think the people on the call do. We all do, like it, because we all know our own area and our own practice, and that's where we need to get to, thinking like that.
Absolutely. There's some really great examples in the rural health space internationally, isn't there, about how things like virtual hospitals have been utilised to actually reach populations that weren't accessing healthcare previously. So I think you're right, there's great potential with the right kind of co-design and input from people who are using services and the clinicians as well. We've run out of time, unfortunately. Natasha, thank you so much for your insights and also your invitation for our community to continue being part of this conversation through the Future Nurse community as well. So we will share that information with everybody that's joined today and more broadly across the early career community. We have really pushed this agenda, I think, for the value of early career and student influence in defining the digital agenda. And one of our questions in the chat was about how it can feel sometimes out of reach for people at this stage in their career. But actually, the digital space is the space where you quite possibly have the greatest expertise, and those that are more established within the profession might not even be able to comprehend some of the ideas that you are bringing and some of the solutions that you can suggest, just because they've been socialized or from a different generation. So we will definitely be continuing this conversation, and all of the theoretical and practical insights that Natasha has shared with us today will be a big part of how we bring this to life. Thank you again, Natasha, for your time. And thank you to all of you that have joined us from all around the world today. We hope that this is just the start of this particular conversation.
I hope so too. You're very welcome, and really want to support people. You know, it shouldn't just rely on their tenacity, but you really are in a position of greater power than you think. I think, as Gemma said, really, and but it's incumbent on Nursing Now and myself. We've just created a reflexive space here in this
Yes,
moment, haven't we? So we're committed to doing more of that and want to hear more from you.
absolutely. Thank you, Natasha. Thank you,
You're right.
everybody. Take care.
Bye bye.
Bye.
Bye.